Hi guys, welcome back for our daily practice questions. It is day 298, and as always, I like to first start with my introduction and disclaimer before getting started with our questions for today. So for those of you who are familiar with me, hey y'all. For those of you who are new here, welcome, welcome, welcome. I am Dr. Brittany Weinstock, a family nurse practitioner and the founder and CEO of the Nursing Studio. I provide resources, tools, review courses, review videos, review books, digital flashcards, Q banks, one-on-one sessions, and more to assist nurses as well as nurse practitioners with success on their boards as well as in practice. I've been doing this since 2015, assisting nurses and nurse practitioners internationally with exam success. But y'all know my disclaimer and reminder is that we know there's no absolutes in medicine. We treat on a patient-by-patient basis, and any of the questions that you see here, I have designed and created based on the current guidelines that are being tested on the ANCC as well as AANP exam. Now, any of my videos where I'm teaching on things that we currently do in practice, I will always say that so there's no confusion. So with that being said, let's get into question number 1 for today. But before we get started, don't forget to hit the subscribe button so you're not missing any of my videos. And if you would like to gain access to my NP Test Success Toolkit, it is free and linked in the description. My website is also linked in the description, and it houses all the resources that I offer. And I always like to direct you to my business profile by simply going to Google and searching The Nursing Studio. It will bring you here where you can find my contact telephone number, link to my website, and testimonials from previous review students. All right, question number 1. A 43-year-old woman presents with fatigue, weight gain, and constipation. Physical exam reveals dry skin and bradycardia. Labs show a TSH of 10.4 and free T4 below normal. What is the most likely diagnosis? Is it A, hyperthyroidism? Is it B, subclinical hypothyroidism? Is it C, primary hypothyroidism? Or is it D, secondary hypothyroidism? Take a moment and tell me what you got in the comments, y'all. All right, so I always recommend reading the stem of the question first, as it allows you to slow down to ensure you're answering what is even being asked of you. So here, the stem of the question states, what is the most likely diagnosis? So, I always tell y'all, if they're looking for a diagnosis, you have to run it back and look at those assessment findings, right? Assessment findings being the signs and symptoms. How do they present? So here we have a 43-year-old woman. She presents with fatigue, weight gain, and constipation. Physical exam shows dry skin, bradycardia, and the lab show a TSH of 10.4 and a free T4 below normal. This is classic for C, primary hypothyroidism. So let's talk about it. Remember, hypothyroidism and hyperthyroidism, the medical terminology is opposite of what the TSH will look like, right? So what do I mean by that? So hypo means low, right? Hyper means high. Hypo being low, the TSH is going to be opposite. So as you can see here, the TSH is elevated, it's 10.4. Whereas the T3 and T4 will be equivalent to the terminology. So you see here that free T4 is below normal. Hypo is low, this is low. So hypothyroidism. Now, if you consider like subclinical hypothyroidism. Anytime it's subclinical, I always say think of it like pre-diabetes, pre-hypertension, things like that. And so what you'll notice is like the TSH will be elevated, but the T3 and T4 will be normal. And that's when it's considered subclinical. But again, here, the best answer is C, primary hypothyroidism. She has the presentation with the weight gain, the bradycardia, the dry skin, the fatigue. The TSH is elevated. The T4 is low. All right, question number 2. A 28-year-old woman presents with severe unilateral headache associated with nausea and photophobia. Over-the-counter NSAIDs have been ineffective. What is the next best abortive treatment? Is it A, topiramate? Is it B, sumatriptan? Is it C, propranolol? Or is it D, amitriptyline? Take a moment and tell me what you got, y'all. All right, and stem of the question, what is the next best abortive treatment? All right, so just like I tell y'all, if they're looking for a treatment, run it back and see if they provided you with a diagnosis. And if they have not, you need to run it back a step further and look and see the assessment findings so that you can determine the diagnosis, because we got to know what it is to be able to treat it. So we have a 28-year-old with severe unilateral headache associated with nausea and photophobia. All right. So when you think unilateral headaches, we think migraines or cluster headaches. Cluster headaches are more unilateral with severe eye pain, tearful eyes, things of that nature, and it's unilateral. Whereas migraines are unilateral and they may have associated symptoms like nausea, photophobia, meaning sensitivity to light, right? So this is more aligned with migraines. So then you ask yourself, for migraines, what is the first line therapy of abortive treatment for migraines? And so your best answer is B, sumatriptan. And then lastly, question number 3. A 56-year-old man has recurrent gout flares and a serum uric acid level of 9.2 between attacks. He is not currently in an acute flare. What is the first line medication for long-term prevention? So again, a 56-year-old man has recurrent gout flares and a serum uric acid level of 9.2 milligrams per deciliter between attacks. He is not currently in an acute flare. What is the first line medication for long-term prevention? Is it A, indomethacin? Is it B, colchicine? Is it C, allopurinol? Or is it D, prednisone? Take a moment and tell me what you got, y'all. All right, and the stem of the question, what is the first line medication for long-term prevention? All right, so we're talking first line therapy for long-term prevention for what? So this patient has gout. This is a gout flare. He has gout flares, but in between flares, his uric acid levels are 9.2, and he is not currently in an acute flare. So what do we do for prophylactic management for gout? And your best answer is C, allopurinol. Remember on yesterday I talked about Brittany's brilliance. The word all is in the medication allopurinol, and this gives us coverage all the time. And also key here, it says he is not currently in an acute flare. This is also very important because we don't give allopurinol when they're in an acute flare, meaning we don't start it, we don't initiate it. But if they are already on it, we don't stop it because you can continue on the medication but we don't initiate it during a flare, okay? All right, y'all. I hope you found this helpful. As always, be sure to like, comment, subscribe, and share with whoever you may think may find this beneficial as well. But y'all know what to do. Make sure y'all meet me back here. And if you need any of the resources that I offer, feel free to reach out to the nursing studio. You can give us a call, shoot us a text message, or shoot us an email. And as always, everything that I do offer is linked in the bio of this channel, including my website. And as I mentioned previously, my website is also linked in the description of this video. All right, y'all. Y'all know what to do. Y'all make sure y'all meet me back here. Happy studying. Bye, y'all.